Good afternoon. Good afternoon to all. It's my privilege to be here with you all, and I would firstly like to thank the Kidney Warrior Foundation, Vasundhara ma'am, Marianne for having me here. Coming to the last discussion, we have had very interesting discussions on kidney disease and various risk factors and how it's important to pick it up early. So, chronic kidney disease is rightly called a silent killer because it doesn't have any specific symptoms, and even if the symptoms which are suggestive of kidney disease, they are attributed to other conditions and are neglected, leading to late diagnosis and progression to end-stage kidney disease. So in this regard, early diagnosis is the key to prevent or delay progression, and the earliest to detect would be before you're born. So before you're born, that is in utero. So who better than the gynecologist to tell us that? So intrauterine growth retardation and low birth weight has been shown to lead to reduced nephron endowment. That is, you're born with reduced number of nephrons to begin with. And there are many epidemiological studies to suggest that low birth weight can lead to increased risk of kidney disease in future and a faster progression to end-stage kidney disease if you develop a kidney disease in your adulthood. So let us begin the discussion with Dr. Kavita ma'am. So how to prevent low birth weight and IUGR, how to detect early, and what interventions as an obstetrician you would suggest which can in the long run lead to decreased burden of chronic kidney disease.
With the latest advances going on in ultrasound, the best part is we detect it early these days. But the point is it available for the rural population? In urban population, yes, we are doing it from the beginning. We are starting our history right from the history. The patient herself was a low birth weight individual. Whether there's any family history, we just get our ultrasounds done right from the 12th week. We pick up if the patient is going to end up with preeclampsia. We know the uterine artery Dopplers. We can do everything when we are sitting in a urban setup. But what's going to happen to the rural population? A simple drug as aspirin can prevent your preeclampsias, it can prevent your FGRs, it can prevent your low birth weight babies. But are we using it in the right composition? Are we still stuck to the olden days where we are still thinking, no, I'm just going to start with the basic which my professor or my teacher taught me. But where are the protocols in place? So the rural population is which has to be benefited. Now the urban population is already benefiting from the things which we are doing, but the ARTs are increasing, the artificial reproductive techniques are increasing, the age of the mother is increasing. So here the incidence of low birth weights, the incidence of FGRs are also increasing. As Dr. As Dr. Kristine said, there is an increase in preterm births. We counsel everything to the patient. We tell the patient about the lungs, we tell the patient about the brain, we tell the patient about how the deficiencies are going to occur for this baby, how the gut is going to take time to get started with, or we talk about necrotizing enterocolitis, but we never talk about kidney, which is very, very surprising, which we never talk about kidney. 500 gram was the low birth weight baby which we have delivered, and we proudly say, yes, this baby is going to go on. Did anybody sit and talk to that parent that this child has to be followed up in future? This child should not let go of the follow-ups in future. So nobody talks about that. So an inclusion and talking about all these things when a baby is going to be preterm baby, talking these important protocols or important things for the patient in the future is very important. First point. Preventing may not be possible with every patient, but at least follow-ups are a must. When we follow up, I cannot go prevent a placental problem. I cannot go prevent certain problems in pregnancy. I cannot prevent rejection in pregnancy, but at least I know how to follow it up. But the problem comes with the rural population. Unfortunately, when you go to a tertiary center, that's where you see all these ladies coming up with still at 190, 100 blood pressures or throwing a fit. There were days when 2004, when I finished my post-graduation, we used to have an eclampsia ward, but that's obsolete these days because of aspirin. And because we know how to use aspirin, low molecular weight heparins coming into place, we prevent many things. But how is it going to affect the rural population? That's where we are going to sit, and that's where we have to insist on the future of the health of women or pregnant women in India. That is where it has to start. It has to start early, it has to start in the rural areas. Urban population fortunately has gone forward with all these things, and we generally talk to them about low birth weights and IUGRs and stuff, but as the ARTs are increasing, twin pregnancies are increasing, the preterm babies are also increasing, talking about follow-ups is very important. And pelviectasis, when we get an ultrasound done, we diagnose a pelviectasis for the baby. Yes, the first trimester, second trimester scans diagnose pelviectasis. We follow up very stringently till the baby is delivered. But afterwards, I don't know what happens to that child. Did I educate them that no, you need to go and get an ultrasound done again after 3 months? You have to. Probably I'm too busy, I forgot to a follow-up. But if you put that in your patient's mind that it may end up in a transplant for this child, so you have to just educate them. Multiple UTIs for a child. UTIs are very rare, if I'm not mistaken, in a baby. But if somebody is diagnosing multiple UTIs, but please just put forward to the parent that they may be just talking to you casually in your OPD that they need to go and get evaluated either by the nephrologist or a pediatric nephrologist. Now we have a subspecialty. So advising a patient, discussing with the patient is more important.
Yeah,
that is the way forward.
Yeah, I totally agree with Dr. Kavita ma'am. And one thing I would like to add is, once we know the child is a low birth weight or an IUGR at risk, again, another aspect we should stress upon is lifestyle. So from the childhood itself, if the child is, the parents are counseled regarding the importance of a healthy diet so that the child doesn't become obese. So obesity is a risk factor. Already he has probably low nephron numbers to begin with. If he becomes obese as an adult, so that will add on to the risk of chronic kidney disease. And to prevent hypertension, a healthy lifestyle from childhood. So these are aspects, I would say these are primordial or primary prevention for chronic kidney disease development. So moving forward now about the mother or about the lady. So I would say pregnancy is really like a litmus test on the kidneys. So kidneys undergo a lot of physiological changes, and lot of kidney diseases are in fact uncovered during pregnancy. And talking about hypertensive disorders in pregnancy, there is a huge spectrum, and now there is enough data to suggest that kidney involvement is an important contributor to the pathophysiology of preeclampsia itself. And again, a follow-up of these patients, I feel post-delivery is very important to diagnose if at all they develop kidney disease in future. And many of these women may have persistent hypertension post-delivery. So again, Dr. Kavita ma'am, what are your views on PIH? Is there lately an increased incidence you see in your practice? And how often in your busy practice you are able to counsel regarding the importance of follow-up of these patients?
Kristine, unfortunately, we have been taught only 6 weeks follow-up. We have not taught the follow-up of, the patient after 3 months also. So that we are never taught. After 6 months postpartum, everything is done. You're done. Yeah. I don't even know you. You don't know me. So that's what happens with everybody. But when we are talking about PIH, is an increased incidence? Yes, but as I told you with the aspirate trial, when they came up and said 150 milligrams aspirin, if you started below 14 weeks of gestation, your gestosis, your PIH is really under control, and early deliveries. Advent of the new NICUs, we were taking care of the babies. Olden days, we were very scared if we deliver a baby before 34 weeks, what's going to happen. So now with new NICUs in place, with the aspirin in place, the advances in the ultrasound, we are able to pick up early, we are going to diagnose early, we are just treating them right way and also giving the results. So PIH definitely is increasing because we are picking them up. Otherwise, we are just seeing the patients with eclampsia, literally. Here, we are picking them early, treating them early. But as you said, follow-up, we just generally get lost after 6 weeks. We don't even see. Nowadays, we call most of the patients, to be honest. WhatsApp me, they send a picture of the wound and say, yeah, I'm fine, doctor. Do you really want me to come to the clinic to show that wound? So that is where the contact between the pediatrician and, the obstetrician and the patient ends. But following them up, and telling them, please at least meet a physician after 3 months. I
think here general physicians can play a very important role, that post-pregnancy, let them have a follow-up visit. The complicated pregnancies, those with hypertension, GDMs during their pregnancy, just an advice to go back to their physician so that there is a follow-up on the proteinuria, on their blood pressures. I think that can go along.
Physician follow-up. So after 6 weeks, generally what I advise in the clinics is, after 6 weeks, please repeat all the tests, including your hemoglobin. Repeat everything. Just go meet a physician. It's okay. Just a neighboring physician is fine. So follow up with a physician after some point of time. I may not be the right person to follow up after 6 weeks, but just you need a follow up with a physician. So that is where we need to, insist on the follow up.
And just a follow up question on this, ma'am. How often or the kidney functions, that is a creatinine and a urine routine, so in periphery especially, in a pregnant woman, what do you think? What percentage of pregnant women would invariably get a creatinine and urine protein during their pregnancy?
Kristine, again here there are two extreme patients. One patient will get me a booklet of investigations and then they ask me to go through everything. I don't even know what half of the investigations are for. Okay, the other patients, they just come when they are completely pregnant, right? So, but I've never had, preconceptional counseling, if you go with the preconceptional counseling, it's all about hemoglobin, it's about the thyroid, it's about sugars, it's about rubella. Beyond that, we never ever ask for a serum creatinine, a basic test. And urine routine, the problems with doing urine routine in pregnancy, especially in the early trimester, is when I pick up some kind of pus cells, most of the times I feel the lab which they go to, I don't know whether the difference between epithelial cells and pus cells are done properly or not. Bacterial, most inevitably they see bacterial infection in that. Again, follow-up of a culture, and again whether I have to treat her, not treat her. Most of the gynecologists do not do urine routine in the first trimester of pregnancy for this reason only. Cultures is what we depend on most of the times, but a simple serum creatinine, which I also never used to practice before, I used to feel surprised, why is somebody asking a creatinine for a young girl? And a simple screening of the kidneys. We do so many ultrasounds in pregnancy. Fortunately, I worked with the best of radiologists who just put up the, just pull up the probe up and say, madam, these kidneys are fine, these kidneys have a problem. We diagnose so many ADPKDs with that kind of radiologists with me. Otherwise, I wouldn't have known, because they just do not share their family history with us, because the husband is sitting next to me.
I think again important role for primary care physicians or those who work with peripheries or patients sometimes in the preconception phase or early on may visit a physician. And also I feel pregnancy is like a mandatory health check for the female. Invariably, many would never get a hemoglobin or creatinine done otherwise. But once they are pregnant, this is probably one of the best opportunities to pick up, if at all there is a undiagnosed kidney disease. Moving forward to Dr. Shefalika, talking about gynecological issues we face in our chronic kidney disease patients. Often we see our female patients complaining of menstrual irregularities, heavy bleeding, even when they are on dialysis. We struggle with the hemoglobin, we struggle with EPOs, they would be having continuous menstrual irregularities. So ma'am, if you could shed some light on the hormonal abnormalities and menstrual irregularities in this group of patients.
Yeah. So majority of the times CKD leads to a lot of hormonal irregularities. Initially, to start with, many of them who are on CKD, menorrhagia is a very common thing. And to worsen the picture, they also have anemia, which is contributed by the kidneys. It becomes like a vicious cycle. Menorrhagia leading to anemia, anemia worsening again, and both are not good in CKD. But then, God has been very kind in these patients. Majority of the times there is a disturbance in HPO axis. So many of them land up with these hyperprolactinemias and increased LH levels, which in turn actually decreases the ovarian reserve. So somewhere though they face a lot of these menorrhagia, which is very difficult to control because you can't keep them, OCPs increase the thrombotic risk, anemia already they have. So whenever that's a combination of CKD and anemia, oral contraceptives which are estrogen containing, they increase the thrombotic risk. So your hands are tied. You can't give them hormones, you can't give them tranexamic acid also. So it becomes a little difficult picture in the initial stages of CKD. But then, as I said, once they progress in the disease, because of the majority of them have these hormonal imbalances, they go for amenorrhea. So that is one thing. I think God is kind enough to reduce their burden. So it's only in the initial disease that you find it difficult, but majority of them, once they go to the dialysis stage, they become amenorrheic because of the reduced ovarian reserve and hyperprolactinemias.
Yes, ma'am. And another discussion in this regard, though we say that fertility is reduced, many times we see patients becoming pregnant. In situations of chronic kidney disease where we are struggling with their blood pressures, they end up being pregnant. So, regarding the contraceptive advice in patients who are chronic kidney disease patients, what is your advice?
I would say majority of them should go to barrier contraception itself or the natural methods of contraception. See, if you look at this group of patients, as such, the fertility is very on the lower side because they have reduced AMH. AMH is the anti-Mullerian hormone, and a lot of these hormonal imbalances lead to reduced ovarian reserve. So, it is very rare to find these CKD patients getting pregnant. If at all by mistake they get, I always tell them you are the priority. So you need to look at your health, and pregnancy and delivering a child which is going to complicate the picture is secondary. See, you should be healthy enough to take care of the child. It is just not getting pregnant and giving birth to a child.
True.
But you should be in a good, healthy, fit and position to take care of the child. So majority of them, they do have lot of infertility problems. Whenever they come to me for the counseling, I would say you are the priority. Just take care of yourself. If at all, if you really want to help, you can adopt a child, which will do good both to you as well and to the child as well.
Totally agree on that.
I never encourage any kind of these infertility treatments. I don't even start any infertility treatments for them.
So for our young patients of CKD, young females, transplantation gives a new lease of life. So post-transplantation pregnancy, what are your views?
Post-transplant pregnancy, I don't do obstetric practice honestly because I am a gynec laparoscopic surgeon. So I
Dr.
think Kavita will be.
I always be post-transplant, post-chemotherapy, give the choice to the patient. You don't decide things for the patient. That has been always in my practice. Lay down the cards. Tell them what is this, what is necessary, what is not, what are your complications, what are the pros and cons. They decide. You don't decide for them. That's been my practice for all these 25 years, and it has always worked wonders. So after 1 year of transplant, give them the choice. It's, of course, Dr. Sundar is here, so he's going to take care of my patients. I'm just going to hand over my patient to them. All I'm going to do is the obstetric type. A teamwork. First, if you have a team in place, like how you guys have a tumor board meeting, I always prefer teamwork in obstetrics. If you have a team who's going to take care of it, I call it maternal medicine. So maternal medicine is something which we have to practice. If I don't give a ray of hope for a patient who has just gone through a transplant or a patient who went through a chemotherapy, they have the right to have their own children. So we have to give them the choice. I would never say no.
Very strong point there by Dr. Kavita. I totally agree. We should sit down together as a team. So it's never an obstetrician says something and a nephrologist says something, the cardiologist says something. So a transplant patient especially, she has multiple comorbidities. So there are comorbidities, but again, as a woman, if conceiving is such an important aspect of her life, we all should sit down together 1 year post-transplant with stable graft function. I think it is not impossible, and when there is a good team, always with the family in picture, talking to every stakeholder, it should be planned. Moving forward, another important aspect of pregnancy and kidney, pregnancy related acute kidney injury. So it can happen at various stages of gestation, and I would like to recollect a patient whom I had seen during my residency, during my training. So she was a young female in her mid-30s with 3 children, pregnant with her 4th child, uneventful antenatal period, delivered in a peripheral center, went into atonic PPH, blood profusely went into hypotension, multiple blood transfusions, oligoanuric, landed up in dialysis dependent state. So these are devastating conditions, and this is one end of the spectrum, and of course there are milder forms of AKI happening in the first trimester, second trimester, which can recover, and these are very important complications of pregnancy, which I say could have prolonged effects on renal, cardiac, neurological, neurocognitive effect, and multiple studies have shown that this can have long-standing impact on multiple organ systems. So, Dr. Kavita, regarding pregnancy-related AKI, what is the prevalence you see among your practice?
Fortunately, very less, Kristen, but you know, as simple a problem as hyperemesis, it may be simple for us, but it is very complicated for the patient. Hyperemesis gravidarum, severe pregnancy vomiting. There are simple medications that can treat them, and you know, as simple as IV fluids are not given to these patients, serum electrolytes are not done. Even you know, we just go to the ketone, and you know, patient has got ketonuria. That's the end of it. We just don't try to treat the patient. Here, either you give too much of IV fluids for that patient, or you just don't give IV fluids at all. 3 to 4 vomitings, you eat, you vomit, you eat, you vomit. That is the advice given by certain doctors. You eat and you vomit, it's fine. By the time the patient sends up to us, she's completely dehydrated, and then we start all the IV fluids, resuscitation and all the stuff. And septic abortions, mostly, I haven't seen a septic abortion in my life, even when I was doing my post-graduation from a government hospital. Very few septic abortions, but right now, septic abortion rate in a urban setup is very, very rare, but still there may be prevalence in the rural setup, I have no clue. So preventing infections is very important. Treating hyperemesis appropriately is very, very important. And then, as I told you, at 12 weeks ultrasound, uterine artery PI, insisting on uterine artery Dopplers, either at 12 weeks or 18 weeks or 20 weeks, we can prevent, or we can at least predict preeclampsia. So prediction of preeclampsia, the other important acute kidney injury happens there. And what I have seen with a lot of patients, a lot of colleagues, which they do, is complete fluid restriction even in preeclampsia patients. Post-surgery, I see them going on 50 ml per hour IV fluid, and what is going to happen to these kidneys, nobody is worried. I want to see my blood pressure slow, I want to see my blood pressure slow. Fluid intake, how much of fluid is going in, input, output, that's very important to measure. The simple charts, if you maintain an adequate hydration for the patient, even post-delivery, this is the same problem. The mother, they hardly give some 2 glasses of water for the patient. So fluid management, predicting preeclampsia, treating hyperemesis, half the time takes away the pain. Your kidneys are safe. But certain diseases, I may not be even seeing them, fatty liver of pregnancies, you know, your thrombocytopenias.
HELLP syndrome.
Very, very rare. HELLP syndrome, preeclampsia, we never let it go till that extent. But before that, these things are very rare, and I haven't even encountered. So probably if you go into a tertiary center, they may be there. And management of these patients will save your kidneys.
Just another aspect on women and kidney health. To Dr. Shifalika ma'am, what are some of the gynecological conditions which in your practice you see can predispose to chronic kidney disease, and there is a lack of awareness?
Yeah. Actually, I'm a gynecological surgeon. Once I've branched out to this specialty, I'm really shocked that you know, there are so many cases of endometriosis that can lead to this silent loss of kidney. You know, dysmenorrhea, that is painful cycles, is a very common complaint that 80% of the women, they suffer with this. Unfortunately, young girls have always been told to ignore this symptom. You know, they are just prescribed some of the painkillers and they are told this is very common. 80% of the women go through this. What great about this? You just pop up some painkillers. Once you get married, once you have children, this will be fine. You know, this is a very, very wrong way of treating dysmenorrhea. I'm shocked to see there is such a high increase in endometriosis patients. I'm not sure because I have this, you know, branched out speciality where I get a lot of referred cases, or whether all other general gynecs, they see so many endometriosis cases. 20 years ago when I was doing a post-graduation, throughout my post-graduation, I had not even seen a single endometriosis case. My biggest fear was, what if the examiner starts asking about endometriosis? Now in my OPD, 30 to 40% of my patients are endometriosis, and I operate at least, you know, 10 to 15 cases of very bad endometriosis. See, what happens in this is, there is something called as a deeply infiltrating endometriosis, where the ureters are affected, and it's the fibrotic disease which starts actually, blocking the ureters. It could be either extrinsic compression because of the fibrosis or an intrinsic ureteral endometriosis, which leads to silent loss of kidney function on that particular side. And unfortunately, if you don't do an ultrasound for a dysmenorrhea or a painful cycle, you never pick it up, because the patient keeps complaining of only the painful cycles. Since the other kidney is functioning well, even when you do a serum creatinine, you will never get to know that the kidney is, the patient is losing the kidney. Only when you do an ultrasound and only when you have an eye that it can cause a silent loss of kidney function, you will pick it up. So one sincere request is, whenever young girls or women come with severe painful cycles that is making them take painkillers, one simple thing that all of us can do is a simple ultrasound abdomen and pelvis, which can always pick up hydroureteral nephrosis, and if picked up early and treated surgically, there is absolutely no medical management for this. I've seen, people getting medical management for years together. Unfortunately, deeply infiltrating endometriosis, which causes kidney loss, can never be treated with medicines. So if they can be referred at a early stage, once this fibrotic disease can be taken care of, lot of kidneys can be saved. Otherwise, we have seen that patients landing up with nephrectomy and all that. Of course, other diseases like fibroids, huge fibroids causing compression of the ureteric disease, majority of the times they get treated early. Or you have complete uterine prolapses or presidentias where there is a vaginal mass leading to kidney loss, is extremely rare, but they lead to recurrent UTIs where that is also a problem. Recurrent UTIs, when it is there, women has to be investigated whether she has got any cystocele or a mass per vagina. If we can pick it up early, we can definitely prevent major problems.
Yes, thank you, ma'am. I think recurrent UTIs are an important aspect of we nephrologists. We see a lot of recurrent UTIs, especially diabetic females. So probably a gynecological evaluation, especially in a female who's having recurrent UTI, is warranted. And endometriosis, thank you for shedding light. I think many nephrologists, I was not aware of this condition at all, that endometriosis can cause obstructive uropathy and renal loss. So thank you for that. I think we can open for a few questions if we have time. Any questions from the...
Thank you for the wonderful talk. I just want to know, when do we call end-stage renal kidney disease? This is the end of it. When do I call that one?
Yes, sir. So, to say end-stage kidney disease, the definition is that it is a stage of kidney failure where the patient needs hemodialysis or other forms of renal replacement therapy to sustain life. So when we look at stages of chronic kidney disease, there are 5 stages based on GFR. Stage 5 is less than 15, but all stage 5 is not end stage. Stage 5 can still be managed medically. So once the patient develops, let us say, uremic symptoms or complications of uremia, is the stage where renal replacement therapy, whether in the form of hemodialysis, peritoneal dialysis or renal transplant, is mandatory to sustain life. So this stage is known as end stage kidney disease. From there, there is no point of return. Any other question? Any question to the panelist? Thank you. So to conclude, I would like to stress upon the importance of picking up early. So we all discussed that how important it is to diagnose chronic kidney disease early, because that makes all the difference. And like previous speakers have also pointed out, we have effective therapies now to retard chronic kidney disease progression. And that is something we all should be aware of. Gone are the days when chronic kidney disease was viewed with, I would say, therapeutic nihilism. You detect an elevated creatinine, the doctor feels that what more can you do? Anyways, it is chronic kidney disease, nothing can be done. So that is not the situation now. We have very potent drugs in various stages of chronic kidney disease. We have the armamentarium to slow down the progression, and in many situations when we can find a specific cause to the chronic kidney disease, there are therapies to partially revert or in sometimes provide a curative therapy also. So diagnosing early becomes very important, and my message to the general physicians out there would be to screen for chronic kidney disease as a part of your regular practice, in those, definitely in those with high risk. And coming to women and kidney, in pregnancy, I feel all pregnant women should have a creatinine and a urine routine at some stage of their pregnancy, even if the pregnancy is uneventful. And in those with hypertensive disorders, preeclampsia, HELP syndromes, even GDMs should have follow-up proteinuria evaluation, blood pressures, and creatinine if they had an AKI, even if AKI recovered during pregnancy, should have a follow-up visit, either with an obstetrician or with a general physician, to ensure we don't miss out on renal conditions unmasked during pregnancy. Thank you. Thank you all.